In this video, we'll discuss myasthenia gravis. Myasthenia gravis is an autoimmune disorder that affects the neuromuscular junction, leading to skeletal muscle weakness. Normally, at the neuromuscular junction, motor nerve terminals release acetylcholine into the synaptic cleft, which then binds to nicotinic acetylcholine receptors in the skeletal muscle cell membrane. This results in an influx of sodium ions into the muscle cell, which raises the membrane potential, creating what's known as an end plate potential. If enough receptors are activated, the end plate potential reaches threshold, which triggers a propagating action potential in the muscle cell that ultimately leads to contraction. In myasthenia gravis, autoantibodies disrupt this process by targeting components of the neuromuscular junction, most commonly the postsynaptic nicotinic acetylcholine receptors. These antibodies not only prevent acetylcholine from binding, but also cause the receptors to be degraded and the postsynaptic membrane to be damaged by complement. Over time, this results in fewer functional receptors that can open in response to acetylcholine, which reduces the amplitude of the end plate potential. Because the threshold is not reached, fewer action potentials are triggered, and the muscle doesn't contract effectively, leading to weakness. The thymus is thought to play a significant role in the pathogenesis, as the majority of patients have some form of thymic disease, such as thymic hyperplasia or a thymoma. The thymus is the site of T-cell maturation, and in addition to lymphocytes, it normally contains scattered muscle-like cells that express acetylcholine receptors. Overgrowth of thymic tissue is thought to promote formation of autoreactive T cells and autoantibodies against these receptors. Although it can present at any age, myasthenia gravis most often occurs in two populations: women between 20 to 30 years of age, as well as elderly men. Patients characteristically present with fluctuating muscle weakness that is fatigable, meaning it gets worse with repetitive use and improves with rest. As a result, the symptoms are usually minimal in the morning and worse at the end of the day. It most often affects the ocular, extremity, and/or bulbar muscles. Ocular muscle weakness, which is the most common presentation, occurs in about half of cases. Patients typically have diplopia or double vision and ptosis or drooping eyelids. These symptoms tend to worsen after prolonged visual fixation, such as with reading or driving. Extremity weakness classically impacts the more proximal muscles, resulting in difficulty rising from a seated position or lifting the arms over the head. Weakness in bulbar muscles can manifest as slurred speech, difficulty chewing, or facial weakness. In severe cases, respiratory muscles may be affected, which can lead to life-threatening complications, as we'll discuss later. Physical examination may initially show normal strength, but there are several maneuvers that can provide clues that a patient has myasthenia gravis. Some examples include asking the patient to look upward for 60 seconds to elicit ptosis, and then placing an ice pack on the eyelids to see if it improves. The ice pack is thought to improve ptosis because lower temperatures help slow down acetylcholine degradation in the synaptic cleft. Other maneuvers include asking the patient to perform repetitive shoulder abduction or hip flexion to elicit proximal muscle weakness, and to count out loud as high as possible in one breath to assess respiratory strength. Because this disorder occurs at the level of the neuromuscular junction, upper and lower motor neuron signs are typically absent, and sensation, reflexes, and autonomic function are usually normal. The diagnosis can be confirmed with serological tests that detect serum autoantibodies against acetylcholine receptors, which are seen in the majority of patients and are very specific. If this test is negative, patients can be evaluated for other less common autoantibodies. Electrodiagnostic testing, including electromyography and nerve conduction studies, may also be performed, which characteristically show decreasing force of muscle contraction with repetitive nerve stimulation due to depletion of acetylcholine stores in the presynaptic nerve terminal. All patients with confirmed disease should undergo mediastinal imaging to assess for thymic disorders. The first-line treatment is an acetylcholinesterase inhibitor, such as pyridostigmine. The acetylcholinesterase enzyme normally degrades acetylcholine in the neuromuscular junction. Pyridostigmine blocks this enzyme, which raises the acetylcholine concentration in the synaptic cleft and increases stimulation of nicotinic receptors, thus improving skeletal muscle weakness. However, pyridostigmine also increases stimulation of muscarinic acetylcholine receptors, which are normal in patients with myasthenia gravis. As a result, it can cause muscarinic overstimulation of smooth muscles and secretory glands, leading to side effects such as diarrhea, sweating, and abdominal cramps. These adverse effects can typically be managed with selective muscarinic receptor antagonists. Although some patients have well-controlled symptoms with pyridostigmine, many ultimately need additional immunotherapy to suppress the autoimmune response. Finally, management may also include thymus resection. Thymectomy is indicated for patients with a thymoma. However, even in patients without thymic abnormalities, it often leads to symptom improvement and may be recommended. A significant complication of myasthenia gravis is a myasthenic crisis, which is a rapid, life-threatening exacerbation of muscle weakness that causes respiratory failure. It can be precipitated by infection, surgery, pregnancy, or certain medications. Myasthenic crisis is often under-recognized initially because the weakened accessory muscles cannot be recruited. As a result, patients can be approaching respiratory arrest before any signs of overt distress are apparent. However, important warning signs may include increasing generalized or bulbar weakness. Patients with suspected myasthenic crisis should be admitted with close monitoring of respiratory function. Another potential complication concerns anesthesia, particularly the use of neuromuscular blocking agents, which induce skeletal muscle relaxation by competing with acetylcholine at the postsynaptic membrane. Because of the low number of functioning nicotinic receptors, patients are extremely sensitive to non-depolarizing neuromuscular blocking agents like vecuronium and are resistant to depolarizing agents such as succinylcholine. Patients must be carefully managed if these agents are needed. To sum up, here are the key points to remember. Myasthenia gravis is an antibody-mediated autoimmune disorder that affects the neuromuscular junction, leading to skeletal muscle weakness. It's most often caused by autoantibodies against postsynaptic nicotinic acetylcholine receptors. The thymus likely plays a role in the pathogenesis, as most patients have some form of thymic disease. Patients classically present with fluctuating and fatigable muscle weakness that primarily affects ocular, bulbar, or proximal extremity muscles. The diagnosis can be confirmed with serological tests which detect autoantibodies in the serum. Management primarily involves acetylcholinesterase inhibitors and thymectomy. A common complication is myasthenic crisis, which can cause life-threatening respiratory failure.